Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you're interested in asking any questions to the guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and the guest speaker will see your questions. Please do not share any personal medical questions or information in the chat box. If you have a personal medical question, please ask your doctor. So next, I would like to introduce you all to our guest speaker, Dr. Daniel Chung. Dr. Chung is a gastroenterologist with the Gastroenterology Division and Cancer Center at Mass General Hospital. He is the medical co-director of the Center for Cancer Risk Assessment at Mass General, as well as a professor of medicine at Harvard Medical School. He joins us today to give a talk on colorectal cancer screening. So please join me in welcoming Dr. Chung.
Hi, good afternoon, everyone. Amy, thank you so much for the introduction. And I am thrilled to be here today to talk about a subject which is near and dear to my heart, and one which has been an important topic for many, many years. And I think an update is important here in 2022 because there are a number of things that have changed in the way we think about screening and the way that we approach screening. So let me just pull up my slides here and then we can get started. Okay, great. So the talk is about maybe half an hour or so, and then we'll have plenty of time at the end for any questions that you may have. I'd be happy to answer. So I'd like to start with just a little bit of background, just so you understand the enormity and the significance of the issue of colon cancer in the United States. It currently ranks as the fourth most common malignancy that's diagnosed, about 150,000 cases per year. But unfortunately, it rises to be the second most common cause of cancer-related deaths in the United States. This is among men and women combined, with about 50,000 deaths per year. And that's number two only to lung cancer. It's estimated that the typical person in the population has about a 5% lifetime chance of developing colon cancer, so that's not trivial. And the vast majority of cases do seem to occur in people who don't have clear-cut risk factors. So it basically means that everyone really is at risk. The principle that we always adhere to in the management of cancer is that the prognosis is directly related to the stage of disease. And so early detection is always, one of the most important goals when we think about when we think about any kind of cancer screening in general. This is just a brief little biology lesson on the way colon cancer develops and what we see during a colonoscopy. I assume many of you may have had already. And what we do know is that colon cancer doesn't just spring up overnight, that colon cancer develops from what we call a benign precursor lesion. And that precursor lesion is something called a polyp or an adenomatous polyp, or as shown in this picture, a tubular adenoma. So here on the far left is a picture of a small polyp. This is maybe about 4 millimeters or so in size. And this is a benign polyp. You have no symptoms if you had a polyp like this. And what happens is over time, once you start developing a polyp, it can continue to grow. And as it grows, it becomes bigger. And so here's a larger polyp that we see, and this is now something called a tubulovillous adenoma, means it's getting a little more sinister looking under the microscope. It ultimately can progress to something even larger that we call high-grade dysplasia. And high-grade dysplasia basically marks the transition when something is still benign, but really just about to become cancer. And what we want to do is prevent this from happening on the far right, which is the development of a true invasive cancer. So we do know on average, it takes about 7 to 10 years for this process to happen. So there's a long lead time. And I think the main message there is that if you then intervene at any of these stages, like here, here, or even here, and remove these polyps, that the theory and idea is that you actually can prevent colon cancer from forming. It's not just really about early detection, but really preventing cancer from forming altogether. And that would be even a better goal to achieve. So as we think about the ways that we screen for colon cancer, there are two main questions that we think about. So the first one is, who do we screen? And the second one is how and how often to screen. So in terms of who to screen, there's actually a pretty simple answer is everyone needs colon cancer screening. But we divide up the way we approach screening based on what your risk profile is. So the vast majority of people, as we say, are going to be average risk. And we'll talk about what makes someone at higher risk in just a moment. But about 20% are in what we call a moderate risk category. And what that includes primarily are people who have a family history of colon cancer. It also includes people who, for example, have had polyps in the past because they are then also at risk for forming polyps again. And the final group, which is the smallest group, is the one who we call high risk. And these are people that are likely to have an inherited genetic predisposition, so that these are people that are part of families where there's lots of colon cancer, maybe other kinds of cancers, and that these cancers are often arise at a young age. So in terms of how and how often to screen, I just want to give you first an overview of what all the various options are. Now, just to put this in context, colon cancer screening is unique in that we actually have many options available. For many other common cancers, like breast cancer, for example, it's mammograms. For cervical cancer, it's doing a pap smear. But for colon, we actually have quite a few options. And so let me take you through them. So the first one is that you can do what's called stool-based testing. This was actually the first generation of these tests were available like decades ago, but this field has transformed so that we now have really much more accurate stool-based tests. And the two that we use primarily are something called FIT and something called Cologuard. The second approach is to do what we call direct visualization, just look inside the colon, see what's there. And the primary test here is going to be a colonoscopy, and in some cases, just a sigmoidoscopy, which is like a mini exam that looks at only the last third or so of the colon. There are some other options, including radiologic imaging. So virtual colonoscopy, which is a CT scan, can also be offered as an option. And finally, there are some molecular genetic tests that can be employed for people who may be at the highest risk. So let's go through these in a little bit more detail. So when we talk about stool-based screening, what we're doing is looking for markers related to the colon polyp or colon cancer that are shed into the stool. And so the two markers that we look for are either blood, because we think tumors like this are intermittently bleeding and we can look for traces of blood in the stool, or what we call sloughed off tumor cells. And so it turns out tumor cells are, as the tumor grows, dead tumor cells fall off and become part of the stool, and you can look for those DNA changes of the cancer cells within the stool. And so the tests here, as I said, was either to look for blood, and that's what the FIT test is. That's called fecal immunochemical test. It looks for microscopic amounts of blood that are in the stool. Or is something called a sloughed tumor cells, where we look for the DNA from cancer cells, and that's the so-called Cologuard test. We'll talk about those in just a minute. Both of these require, providing a stool sample in a container and then sending it in. It's not particularly difficult to do. It may not be the most pleasant thing to do, but it's actually pretty simple and straightforward. One of the big questions in the field always is, are stool tests helpful if you want to try to find polyps? And we'll show you a little bit about what some of that data, but in general, it turns out that stool tests generally are not quite as good for picking up polyps, because polyps are much less likely to bleed. Polyps are much less likely to slough off tumor cells. And so it's less likely that you're going to pick them up with a stool test. So this is the main study that came out. I'm not going to go through a huge amount of detail, but this came out almost 10 years ago, which showed that the stool DNA test, or Cologuard, how effective it was. And so the bottom line here, this is the test showing how many of the cancers it picked up and basically how many it missed. And so sensitivity for cancer means of all the cancers in the study, what percentage were picked up by the DNA test? And 92% were picked up by the DNA test. And you will hear that number a lot, gets advertised a lot. If you just look at the occult blood FIT test, about 74% of the cancers were picked up. So not quite as many, but actually pretty good number. The point here that I made earlier was that if you look at these tests for how well they pick up adenomas or polyps, and specifically what they looked at here were what are called advanced adenomas, meaning they're particularly big, that the sensitivity falls quite a bit, so that it's only about 24% for if you use the blood test, only about 42% for the DNA test. So it performs quite well for finding cancers, not so great for finding polyps. And so in terms of pros and cons, I kind of mentioned these a little bit earlier about using stool screening, is that it's definitely cheaper to do a stool test. It's definitely easy to perform. You don't have to take a day off. You take a kit home at work. You take a kit home, do it at home, mail it in. And we do know that it's effective, that you can actually, there are lots of testings that have shown that if you screen this way, you will find cancers and you reduce deaths related to cancer. But the cons are that, as I mentioned, some people just are not, there's a little bit of an ick factor of dealing with stool. Any positive test then requires going on to do a colonoscopy afterwards. It turns out the benefit may actually be greater with other screening tests, so that you may be missing out a little bit if you just rely on stool only. And if you do the stool test, you actually need to do them much more frequently. So for example, the stool blood test needs to be done every year, whereas for a colonoscopy could be every 10 years. And so there is that factor that needs to be taken into account as well. So colonoscopy, and if we move on to what we call the direct visualization test, colonoscopy is the most commonly used test here in the United States. And this is a highly schematic view showing the tool here being inserted through the rectum. And what it does is you can navigate all the way through the whole colon like this and look at the entire colon and the lining in the way that I showed you those pictures early on. And so in that way, you get a direct view of the entire colon. And a sigmoidoscopy means you just only go about this far where the green is. So you only see like the lower third. And so, as I said, this has become the standard here in the United States. It's not so true in other parts of the world, but here in the United States, this has become the standard, primarily because it's felt to be a more comprehensive exam for the entire colon. You get direct visualization, and if you see something, you can take it out right away. And then the goal here is also that you can actually find these so-called precancerous polyps. And theoretically, that's going to help prevent colon cancer from forming as well. So this is the data that actually shows that this whole concept of prevention is actually a very achievable. And this data are actually quite old, but there haven't been comparable studies to reproduce this, but the so-called national polyp study was performed. Basically, people who had colonoscopies had polyps removed. And then what the investigators did was look over time to see how many cancers developed in those people who had these polypectomies done. And it turns out that this is the group, this bar right here, are the people who had polyps removed and over 7 years of follow-up had very low rates of colon cancer formation. And that, if you contrast that to a lot of other population databases about what the number of colon cancers you'd expect to see, there was anywhere between a 75 to 90% reduction in the number of colon cancers expected over that 7-year time period. So that is like a real home run to be able to then prevent colon cancer from forming at all by removing polyps. Now, Colonoscopy is not perfect, and so there has been a lot of interest in making sure we figure out how to do colonoscopies well, and you get the full benefit of the colonoscopy. And you will hear about these a lot, and you can certainly ask your gastroenterologist. There's something called an adenoma detection rate, which is something that is unique to each endoscopist. And it means that on average, a good quality endoscopist should find at least 20% of all women that he or she scopes has an adenoma, or 30% of all men or women has an adenoma. And if you know they're finding that, then that means you know they're doing good exams. You know that we do know that people need to make sure they do complete exams, that they really reach the far end, and that's what fecal intubation rate means. And the last one, which is relevant for all of you when you do have your colonoscopies, is that the prep, the bowel prep quality is absolutely critical. So if there's a lot of fluid or stool left, there are things that can be hidden or missed, and the endoscopist just cannot see them. What we have learned is that the best way to get a really good prep is to do something called a split prep. And that means you do about half of it the night before, and then you do half of it about 6 to 8 hours just before your procedure. Can unfortunately mean getting up in the middle of the night to do it, but it does mean that there is a greater chance that things will be entirely cleared out by the time you have your procedure, and that is what you want to make sure you accomplish. So virtual colonoscopy is an option for people who can't tolerate a true colonoscopy, and this is basically a CT scan. So you lie in the tube, takes images over your colon. You do get air inflated into your colon. Images get reconstructed through a computer, and you can get images that look like this, where the radiologist can say, oh, there's a polyp located there in this part of your colon. And then in those cases who have a positive result, would then go on to have a real colonoscopy to take the polyp out. Now, it turns out that virtual colonoscopy works actually quite well for finding large lesions. And we say large is greater than 10 millimeters or a centimeter. And so these are variety studies in general that show up to 90% of the time you will find, when things are that big, you will find them with a CT scan. The problem is that for smaller lesions, meaning less than 10 millimeters, your pickup rate is going to be much, much lower. And so you're more likely to miss those polyps when you do the CT colonography route. And so there's a little bit of a disadvantage there where you're not getting quite as much of a benefit of finding and removing those smaller polyps. I think that what has happened with this particular modality is that it does have its merits. I think what has happened is that in most cases, it's actually not covered by insurance. And so that has become a little bit of a barrier to having it become more widespread. So in terms of recommendations then, what we say for the so-called average risk patient is this is all men and women over age 45 and over, have no symptoms, and have no risk factors, meaning family history, inflammatory bowel disease, or prior polyps. Now, the one big new thing here in 2022 is that the age at which we start screening has been lowered to 45. It used to be 50. We now know that there are more and more cases of colon cancer occurring in younger individuals, less than 50. So right now, the age to start, if your average risk, is 45. So a number of societies have reviewed all of the different modalities and have come up with a tiering system that recommends that you ought to pursue something in the tier 1 category. I mean, these are the ones that are more effective, more cost effective, and have demonstrated benefit. And so that's either going to be a colonoscopy every 10 years or a FIT stool test looking for blood every year. So if you cannot or do not want to do those, the secondary tier would be to do colonography, the CT virtual colonoscopy every 5 years, do the Cologuard, the fecal DNA, every 3 years, or to do a sigmoidoscopy every 5 to 10 years, okay? And so I think that these options are good to know that these are available, but we generally think that doing one of these two is probably the best way to do for screening. Now, that's average risk. So for moderate risk people, as I said, the main risk factor in this group are people who have a family history. And this graph just shows the extent of the increased risk you had if you have a family history. And to summarize, basically, if you have one first-degree relative, meaning sibling or parent who has a colon cancer, you have almost a twofold increased risk. So instead of about a 5% chance, you have about a 9 to 10% chance of developing colon cancer. And we know that if you have 2 or more relatives, or your relatives are young, less than 45, those risks shoot up even more to 4 to 5-fold increase over the baseline. So what are the guidelines if you do have a family history? It's actually quite simple right now that if you have colon cancer in a first-degree relative of any age, you should start earlier. Meaning instead of 40, or it used to be 50, but instead of 45, you should start at 40. And you start 10 years before the youngest case. So if you had a relative that was 45, you'd start at 35. And then you do it every 5 years. Now, the interesting nuance here, which is sometimes hard to dissect out, is that we also include people who have what are called advanced polyps. If you have a relative who's had an advanced polyp, and that means like a particularly big polyp, or it had features of very early cancer in it, that those people you should treat as if they've had cancer and use these recommendations. But relatives who've had kind of the small, benign, incidental polyp, those would not qualify for this enhanced sort of surveillance. Now, we do know if you've had prior polyps that you need to be scoped more frequently than every 10 years. And so the interval is, I'm not going to get into the nitty gritties of this because it gets a little complicated, but it depends on how many polyps you've had, what size they were, what specific histology. And based on those, you follow-up would range between anywhere to 1 to 7 years. And so you need to rely on your gastroenterologist and your primary care doctor to kind of dissect what you've had to come up with the right interval. But the bottom line is if you've had polyps before, you should not just be kind of on a routine 10-year interval. Okay. I do want to just say one word about the so-called high-risk individuals. And these are individuals who are part of what we call a hereditary colon cancer family. These are quite rare, but important to recognize if it's indeed present. And the most common syndrome is something called Lynch syndrome. And the things to know about Lynch syndrome are that you see cancer in many generations. The colon cancer risk can be as high as 60%. That's in contrast to that 5%. Cancers can be earlier. There often are very few polyps in the colonoscopies. We see a lot of endometrial cancer in these families as well. And the main message is that there are genetic tests that can be done, blood tests, that can help figure out whether you have Lynch syndrome or not. And we look for changes in one of these genes. And so if you see a strong family history or young onset colon cancer in your family, you ought to consider an evaluation and a genetic workup for Lynch syndrome. So there are a couple of interesting questions that always come up about screening. One of them is, when do you stop? And this is a tricky one. And some basic guidelines have been put forth, and these include everyone probably ought to have routine screening until you're 75, assuming you're pretty healthy. Between 75 and 85, maybe not such a good idea, but if it would be individualized. For example, if someone is really quite healthy in that interval, but sure, you can consider going ahead and doing screening. But everyone over 85, probably not worth doing any additional screening for average risk individuals. However, this does not apply to people who are undergoing surveillance because they've had lots of polyps before or have a strong family history, or someone who's in one of these very high risk categories. So I think that 75 is the age to kind of keep in mind if you're in that average risk group. All right. The good news here is that all of these efforts seem to be paying off. These are nationwide data that show the incidence and mortality for colon cancer over the decades. And these are all with different groups, white, blacks, Asian Pacific Islanders, Hispanic, and which have shown that in both men and in women, that the incidence is steadily going down. And this is the data, we don't have the more recent one, but these all continue to be true, that it continues to keep trending down. And mortality also continues to keep trending down as well. Now, even though we're doing much better, there still are a lot of cases. And as I showed you in the original slide, it's still the second leading cause of cancer-related death. So we still have a ways to go. So part of that problem is that not everyone is getting screened who should. And so as I mentioned, it should be near, everyone is a candidate for screening. And realistically, that generally translates to over 80 to almost 90% of individuals who probably ought to be screening actively. Turns out that we're only about at 69% of the population who is caught up with their screening. And so there's definitely some room to move here where we ought to make sure that people are aware of the need to screen and the options to screen and to get them screened. Interestingly, people who are older tend to be more compliant than people who are younger. These are individuals in their 50s, these are individuals in their 70s. But I think if we're going to make headway and reduce some of that risk in the younger individuals, we need to be approaching, doing just as well with the younger population here. A quick word on what's in the future. So screening, as I said, continues to change. One of the newest things is that there are now enhancements to colonoscopy, and one is something called artificial intelligence or computer-aided detection of polyps. And so there's now software that helps the endoscopist look at the image on the screen and identify polyps that the endoscopist may have otherwise missed. And there's several of these devices that are being investigated, and one that has actually already been approved by the FDA for use. The second is something called a colon capsule endoscopy, and this is a camera capsule that you swallow. It makes its way through your whole intestine and comes out your colon and gets pictures as it travels through your colon. So it sounds like really attractive and easy. The issue here is that right now, it has no therapeutic capabilities, obviously, and it doesn't really give you can't control the full view that you're getting of the colon. So right now it is FDA approved, but only for those who were not able to have a regular complete colonoscopy, either because of other illnesses or they had one and it was incomplete. And in terms of the research side, there are now a number of companies that are studying a variety of blood markers that may be useful markers for colon polyps and cancer. And the idea here being that you do a blood test, and only if the blood test is positive, do you go on and do a colonoscopy. So I'd like to summarize here with what I hope have been some of the key messages that to share with you. The first one is that everyone needs colon cancer screening, and there's lots of options. So whatever works for you is the one that you should do. The age of initiation of screening for the average risk person is now down to 45 years. So in terms of the preferred and tier 1 options, those two are either colonoscopy or FIT, which is a stool test for occult blood. So it's important to make sure you know what your risk category is. And most commonly, this is really about knowing what your family history is for colon polyps and cancer. It's important to do high quality exams. If you're going to go through the colonoscopy, you got to make sure it's a good one. And in most cases, at least on your part, what it means is making sure you do a really good prep. And finally, always keep an eye out for whether or not there may be lots of cancers in your family or at young ages may warrant a specific genetic evaluation to identify one of these high-risk syndromes. All right, so that is the end there of my presentation. I thank you for participating and joining, and I'm happy to take any questions that you may have now about any of this content or anything else related to colon cancer screening.
Thank you so much, Dr. Chung. As mentioned, feel free to enter any questions you have in the chat box for Dr. Chung. So there is a question about risk. Aside from family history, what are other ways may one assess for their risk for colon cancer?
Yeah, so the main, so if you've had a personal history of polyps, that puts you in a higher risk category. If you have a personal history of what we call inflammatory bowel disease or frequent colitis or Crohn's, that does put you at higher risk and you need to have more regular screening. There's been a lot of interest in trying to figure out, about lifestyle and environmental risk factors and how that impacts screening. So we do know there are a number of things, such as people who are heavy smokers, people who have diets that are high in red meat, people who drink alcohol regularly, and people who are very overweight all have a higher risk of developing polyps and cancer. So, we officially don't put those into these guidelines because we have not really quantified to figure out how to quantify each of those and how those translate to risk estimates. But those are all things that I think that are things that you can be doing to monitor and modulate your own risk.
And would this be a conversation they would have with their primary care physician?
Yes, exactly. I mean, those are sort of things where you can try to quantify which of these categories are relevant for you, and then really try to come up with plans about how you can address each of those. Because I think that many of those things, it's not, if you are a regular smoker, it is hard to quit. I mean, and so but I think that there are strategies for each one of these, and you can try to work with your doctor about which of the strategies are the most relevant or most important to try to modify.
Thank you. We have a participant who have heard they revised the prep since they had their colonoscopy 5 years ago. What is the procedure these days?
All right, so the standard prep has been something called Go Lightly, New Lightly, which is a big 4-gallon jug of something called polyethylene glycol. And over the past couple of years, that has actually not been available. It's been back ordered, and that's why you may not seeing it being prescribed as much now. It's still the ideal prep, but because it's now supply chain issues, that it's not really been available. So that is why many of our patients now are doing either what's called the miralax prep, which is sort of a smaller abbreviated version of that, or there are a number of new very small volume prescription options that are available, like Movi Prep or Suprep, which are options. Sometimes their insurance coverage may not be quite as good for those, but all of them actually work pretty well, and that's the main thing that has changed, is that the big jug thing is just not available. I think that will ultimately come back to become our usual prescription, hopefully within the next year or so.
Thank you. How does one know if they have a small intestine problem?
That's an interesting question. So the colon, as we've talked about, is the large intestine. The small intestine, there's about like many feet of small intestine just connected to the large intestine, and the small intestine is where you do all your digestion and absorption of nutrients. So just as far as cancer goes, the main thing with the small intestine is that the small intestine cancer is exceedingly rare in the small intestine. And so we almost never screen for cancer in the small intestine, and people just generally do not need to worry about that. I think that most of the problems with small intestine, and this is kind of really separate from cancer screening, is that, because of its function, I think when people have problems with the small intestine, it really can manifest more as either things like diarrhea or weight loss, sometimes some pain, cramping, and those are associated with usually typically inflammatory disorders or disorders in which you don't absorb or digest food as well. And those are the kinds of things we think about in the small intestine.
Thank you. How frequent are problems from colonoscopy, including perforated colon from colon removal or hernia?
Yeah, so colonoscopy does have certain risks, and so the main ones really are bleeding. So if you remove a polyp or take biopsies, there's always a chance you can bleed. So perforation is another one, and what perforation is, it's a little puncture, a hole through the lining of the colon. Now it is quite rare, and I will tell you that. So it's estimated in between 1 to 1,000 to 1 in 2,000 cases that happens. So it is quite uncommon. It can occur in people who are at higher risk for this to happen are people who may have a chronically diseased or thinned out colon, or if someone is removing a particularly large polyp. So in most cases, really perforation is really quite rare. It's not zero, but I think that we do think that the risks are pretty low. If you do have, and we think about chronic illnesses being often people who are on long-term steroids, or people with chronic inflammatory bowel disease, maybe, or ischemia are the ones that might be at higher risk. But in general, you should not be too worried about that. The other risk, just to be complete about the procedure, is that sometimes is recognizing that colonoscopy is not perfect, and that sometimes there are some things that may be not seen. And we do recognize there is a very tiny rate of, again, missed polyp, rarely missed cancers, but it can happen. And we do know, and that is really one of the main reasons why it's important that you do a really great prep, because those are the kind of things that can be hidden behind leftover stool in the colon.
Thank you. Is cancer prevalence in relatives other than colon or endometrial a factor?
Cancer, yes and no. I mean, I think in general, so if we're thinking just about colon cancer risk, we look primarily at other relatives who've had colon cancer, and then we look about endometrial if we're thinking about Lynch syndrome. It does turn out there are in terms of genetic syndromes, there are other syndromes where colon can also co-occur with other cancers as well, like stomach cancer sometimes, rarely pancreas cancer, and so sometimes ovary cancer. And so we do think that it's important to have a good sense of your cancer family history overall. I mean, when we're doing colon cancer risk, we're most interested in other relatives with colon cancer, but that doesn't mean, like, you know, you may be at risk for some other cancers based on your family history of other types of cancers. And so so we do encourage you to make sure you have a good, complete cancer family history.
Thank you. We have an individual who had the miralax Gatorade prep, much easier, but is it as effective if we go back to Go Lightly?
Oh yeah, so the miralax prep is, I would say that most of the data would say that it is almost as effective. So it's very good. Really can give you an excellent prep. I think that on average, the Go Lightly will give you a little bit better prep. And I think this is sort of where, if you follow instructions closely, even with the miralax prep, if you follow instructions closely and you keep drinking until things do come out clear, you're fine. I mean, you know, clear at the end, clear is clear no matter how you get there. And so I think that you can get excellent results with the miralax. It's just a matter of being really fastidious about following the instructions till you get that good prep. I will say on average, the Go Lightly is going to give a slightly better prep though, which is why it had been our standard.
Can you give us more information on the relationship of endometrial cancer to bowel disease and risk factors?
Yeah, so I think that most cases of endometrial cancer are not related to colon cancer or bowel diseases. It's just that we do know that there is, and we'll just talk about Lynch syndrome specifically, that individuals who have Lynch have a high risk of both colon cancer as well as endometrial cancer. So if you have, you know, one relative who's had endometrial cancer, or you've had endometrial cancer, and there's nothing else going on in the family, you know, it's likely that that was what we call just sort of a sporadic, isolated case. But, you know, if you had endometrial cancer when you were quite young and you were 40, and your mother had endometrial cancer, and then, you know, your brother had colon cancer, you know, that's a scenario where we'd say, okay, well, it looks like something might be going on, and you need to add up those cases of endometrial and colon together to consider what's going on. So in most cases of endometrial, I would say, yes, you don't need to worry, but you need to look at it in the context of, are there many other cancer diagnoses that go along with this as well?
So we have a question. Should people who have fundic gland polyps in the stomach be screened again?
Interesting. Okay, so in general, no. So fundic gland polyps are benign polyps that can arise in the stomach. In most cases, they are due to taking proton pump inhibitors like omeprazole or Protonix or Nexium kind of long-term as just a side effect. They're generally benign and don't cause any symptoms. So in most cases, no, you don't need to do anything about them. The one exception is if you have so many and they're so large that can be associated with the presence of multiple colon polyps. So there are what we call colon polyposis syndromes, where people have hundreds and thousands of polyps in the colon. And one of the features of that condition is also having lots of fundic gland polyps in the stomach as well. So if you have a few fundic gland polyps and you've had a normal colonoscopy and you're taking, Prilosec, that's probably what it's due to, and you don't need to worry about it. But if you have really what we say carpeting and lots of big and large fundic gland polyps, then it would be worth making sure that you don't have lots of colon polyps at the same time.
Thank you. Are there diet or other factors that can reduce the risk of polyps, especially precancerous ones?
Yeah, so some of those dietary things that I talked about are all things that are associated with the risk of both polyps as well as cancer. And so just to recap some of those, so in terms of diet, so red meat is one of the biggest offenders there. And so we say that put yourself in the lowest risk category for both polyps and cancer, it's generally having like 2 or fewer servings of red meat a week. So alcohol is another risk factor, and so for both polyps and cancer. And so we would say, trying to limit it the most to like, a drink a day. People who we do recommend that diets that are high in natural fibers can actually be protective. And so that means, natural like fruits and vegetables and, grains is protective as well. Smoking is the other one. It's not really a diet, but smoking is clearly also another risk factor. You should just stop smoking. The one interesting thing that always comes up is whether there are medicines that you can take that are called chemopreventive, meaning it's a safe medicine you just take on a regular basis and actually prevents the formation of polyps and cancer. And there's a lot of interest in using aspirin in this regard. There has been data that suggests that aspirin can indeed reduce number of polyps and cancers. You have to take it for a long time, for over 10 years. And the problem is that, when you take it that long, there's always a good chance of side effects, meaning bleeding or ulcers. So it is a recommendation that I think is being individualized right now. We don't routinely tell people just take aspirin to reduce polyps and cancer, but it's one in which you clearly need to discuss that with your primary care doctor. And we are now focusing really on people who should be taking aspirin for cardiovascular preventive purposes, and then really at the same time reaping the benefit for polyp prevention as well.
Thank you. Why does alcohol promote cancer? Is it chemical related?
Oh, that's a great question. I don't think we know specifically. There are a number of potential theories. I mean, some of it has to do with, alteration, the metabolic pathways in the colon cell. Some of it may be related to altering what we call the microbiome, the bacteria in your gut, which can influence colon polyp and cancer formation. And some of it can be related to the way it may affect your immune system. And if it suppresses your immune system in some ways, that can then make you more prone to cancers, because the immune system plays a role in what we call surveillance of fighting off early cancers. And so having that that slight immunosuppressive effect on a long-term basis can also have an effect that way.
Thank you. So I'll give it another minute to see if anyone else has any final questions. Any final thoughts you'd like to share with the audience?
No. I mean, I think these are all great questions, and I think that the main thing I would just emphasize is that if you haven't done screening, you really ought to make sure you do it. And in terms of all of your other close family members, relatives, it's really worthwhile to make sure that you understand the cancers in the family, as well as make sure everyone does their regular screening. Okay.
Well, thank you so much, Dr. Chung. As I had
Okay.
mentioned, this session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
All right. Thank you. Bye-bye.